All right. Hello and welcome back. I'm Eric, your host of the Doc Buddy Journal. And today we're joined by Dr. Dan Blumenthal, who's a practicing board certified non-invasive cardiologist. He's president of the Novo Cardio Division and also an instructor at Harvard Medical School. Thanks for joining us, Dr. Blumenthal.
Thank you for having me.
Absolutely our pleasure. And that's a pretty short and concise intro. What else should our audience, what else should our listeners know about you?
Yeah, so I am the president of the Novo Cardio Division of Cardiovascular Associates of America, which is a large cardiology-focused practice management platform. We partnered with over 360 cardiologists across 8 states and about 200 advanced practice providers as well who work in the 19 practices that are part of CVA USA. And Novo Cardia is the value-based care division of Cardiovascular Associates of America. So we are focused, and I spend all my time day in, day out thinking about how we can improve the care model in these practices. So meaning improve the quality of care that our physicians deliver for patients with heart and vascular disease, and how we ultimately try to help transition how they're paid. Our physician partners are paid for care from traditional fee-for-service mechanisms to more value-oriented or risk-oriented payment models, which reward the delivery of higher quality, more efficient care. So that's what I do on a daily basis when I'm not practicing cardiology, which I still do several days a month, and then I also do some inpatient work at a hospital here in Boston.
Well, it's quite the privilege to have you on our podcast because you sound like an incredibly busy person with a very full calendar. So thank you once again for joining us.
Of course, my pleasure. Thank you for having me. Yeah, we've been building a really interesting, exciting set of care model innovations at CVA USA and Novo Cardia, which are, again, really geared towards helping to deliver better care for patients with heart and vascular disease who are receiving care from community-based cardiologists. And happy to tell you more about a lot of that work. I'm excited to kind of to delve into some of the details there and also kind of talk about some of the levers that we pull to drive improvements in quality and reduce costs.
Me saying this is not meant to be tongue in cheek, but when you talk about improving outcomes and value-based care, the cardiologic system strikes me as a very high priority for a high quality outcome. Not that the rest of the systems of the body aren't important or complex, but speaking cardiologically, that seems mission critical. So what are some of the things that are front of mind for you to ensure that happens, either through the use of technology, through the use of care protocols? You're the physician here. I'm certainly not, and I don't want to pretend to be.
Yeah. So you're exactly right. So cardiovascular illness is ubiquitous, particularly in older adults, right? It's very expensive. So if you look at recent projections, depending upon whether you're looking at data from the American Heart Association or the American College of Cardiology or from other published projections, anywhere from 40 to 50% of older adults in this country will develop one or more cardiovascular illnesses. And the cost of caring for those diseases is extremely high already, projected, or an estimated $320 or so billion a year is what we spend in this country on cardiovascular disease care. And is projected to more than double by 2035 to something like $750 billion per year. So, those costs can be measured as a percentage of GDP, which is pretty astounding, right? Somewhere in the range of 2% of GDP spent on cardiovascular disease care. So it's common, it's costly, and there are lots of opportunities to help care for it more proactively, prevent it from developing in the first place. If it develops, prevent it from progressing. or progressing as quickly as it otherwise might. And a lot of that work relates back to thinking about how we help ensure that our physicians have access to supports to help them deliver evidence-based cardiovascular disease care. And one of the things that I love about the field of cardiology is that there's so much data and evidence to guide how we practice. We, in many cases, really do. There's certainly a lot of room for clinical nuance and decision making, but in many cases, we do know what works and what doesn't work, and so we can really help patients. And a lot of that development of knowledge is a result of a lot of hard work that has been done by cardiologists, by academic researchers, by the NIH, by funders from pharma and biotech and device manufacturers to build the evidence base about what does and doesn't work. And so we can use a lot of that information to help ensure that patients are receiving the right care in the right place at the right time. And then when it comes to thinking, go ahead. Yeah.
I was going to say, I hope I'm not jumping tracks on your train of thought here, but one of the things I'd be curious about your perspective on is you listed all of the great sources of research for the empirical evidence of what works and what doesn't work. We're 14, 15 years into the big electronic health record experiment in the US. And it's here to stay. It's not so much an experiment, but something new, something mandated. I would imagine that despite the fact physicians on average don't care to be their own scribe, don't care to be spending all of their time in their EHRs, there's got to be some good that's come from that amount of data collection that didn't happen before the Meaningful Use Act.
Yeah. No, there's a ton. I mean, so I think there are a number of areas of where that data has started to has become really valuable. One is, and we have access to all of the EHRs that our physicians use, and they use a number of different EHR systems, and we've tapped into all of those systems, and we're aggregating information. We can start to understand variations across practices in care patterns, right? What percentage of patients follow up and see their cardiologist after being discharged from the hospital? Where care is being delivered, how much of it is being delivered in the clinic versus in the hospital versus in a different location. And that becomes very relevant when you're thinking about procedural care, in particular in cardiology, because many procedures can be done either in a hospital or a hospital outpatient setting, or they can be done in an ambulatory surgery center or an office-based catheterization lab, which is like an ambulatory surgery center, but has been licensed for a narrower set of procedures that can be done in an office-based cath lab. So we can start to look at where procedures are being done and whether they're being done, what types are being done more commonly in the hospital versus in an ASC or vice versa. So just two examples. We can also look at medication prescribing, whether patients with heart failure are receiving evidence-based guideline-directed medical therapy, which is, again, has a lot of evidence behind it from randomized trials and observational studies. And we've started to look at those data to help understand whether our patients with heart failure are receiving the right kinds of treatments. Not that every patient with heart failure should receive every single one of those medicines, but at a population level, you can start to understand how commonly they are being used or not used. And that helps us to then think through how we help support our physicians to understand what they're doing and to make improvements in what they're doing, or to continue to do the right things if they're doing them already at a level that is, that many of them are, but some still at times need some additional guidance on. So right. just a few examples of how those EHR data are being used, on a daily basis, and in some cases, that work is ongoing to build the right data feeds or the right analytics once we have the data feeds to understand different types of care patterns and variations in care.
That's EHR data for good. And I know that is like the number one self-reported cause of frustration with being a physician as a career. Now,
Yeah.
go back to, go ahead, doctor. I was jumping tracks on you.
No, all good. Keep going.
You mentioned a stat. It was a percentage of folks that were going to end up with a cardiovascular disease going forward. And it was a big number, 40%, I think you said.
Yeah, I think I mean, the projections vary depending upon, what ages of people you're talking about, and whether you're including conditions like hypertension and hyperlipidemia or high cholesterol, which are, which are more prevalent and affect a substantial percentage of adults. But something between 40 and 50% of middle-aged adults and older will develop some form of heart disease. Yeah.
Kind of a two-part question there. I guess maybe a three-part question, but how could that possibly be? That seems like a staggering proportion of a general population. How does that stack up over time?
Well, how much time do you have? When I say heart and vascular disease, I'm talking very broadly about not just coronary artery disease or blockages in the heart arteries, but also heart arrhythmias, atrial fibrillation being the most common, congestive heart failure, which we just talked a little bit about, peripheral artery disease, and that ischemic cerebral ischemic disease or cerebrovascular disease. So again, I think the definitions, kind of will impact the percentages. But if you include all of those, meaning people who have had strokes or will have a stroke, people who will develop heart failure, people who will develop blockages in their heart arteries, people who will develop abnormal heart rhythms like atrial fibrillation, people who will develop peripheral artery disease, you're talking about a very large number of the American population.
But is that
lives?
Is that getting better or worse over time? How do we look compared to Europe? I know I'm just kind of firing questions at you, but that is truly staggering, the statistics there.
Yeah, so it has improved, and I'm over the last 50 years has the rates of heart and vascular disease have declined, and rates of death from those illnesses have declined, and in large part the decline in the rates of heart and vascular disease and poor outcomes in particular from heart and vascular disease are a result of reductions in rates of smoking in this country, better treatment of high blood pressure, better treatment of high cholesterol, which are all three of which are major risk factors for the development of heart and vascular disease. I would say, rates of diabetes have increased, and so that has been a countervailing trend and force in driving sustained rates of heart and vascular disease, because diabetes is an important risk factor as well. But I think the work that we've done in public health, experts deserve a ton of the credit here, as do physicians, both from primary care and cardiology and other fields. The overall, we have done a lot of good in terms of reducing the severity of and the rates of a lot of those risk factors for heart and vascular disease.
I'm glad to hear that things are improving despite some of the countervailing measures, because at first blush,
there's a but. In recent years, they have stagnated. Those declines have stagnated, right? So we've kind of plateaued. And in some cases, and particularly for certain populations, rates of heart and vascular disease have started to increase again. So we cannot give up, and we can't lose focus. And I think our specialty societies have continued to remind us that we can't lose focus in terms of our ongoing efforts to drive improvements in not just outcomes, but also rates of development of these illnesses.
You're reading my mind there, Dr. Blumenthal, because this is an arena where it sounds to me as a non-physician, non-provider, that an ounce of prevention isn't worth just a pound of cure. It's worth maybe a ton of cure. I mean, I would imagine a lot of these conditions are tough to reverse once they've sort of taken hold. And you said something just a little bit ago that, the state of the art is to be able to deliver the right care in the right setting at the right time.
Yeah.
And I would imagine that's often tough to do, whether you're talking about an intervention or whether you're talking about preventative guidance to a patient. I would imagine that's tough to do without the right technology in play.
Yeah. Yeah, it is. And that technology, I think there are a number of ways in which we think about the use of technology in our organization to help drive better outcomes. We think about, and I'll talk about two of them. I think we think about expanding the bounds of the clinic into a patient's home through remote monitoring, through virtual care, telehealth, to try to ensure that we are managing patients in between their in-person visits more closely and more efficiently. And that remote monitoring can take the form of a number of different interventions. It can be anything from remote blood pressure monitoring to, more frequent downloads of data from implantable devices that are gathering data. They're already in a patient's body, like a defibrillator or a pacemaker. Our pacemaker and defibrillator technologies have advanced to the point where you really don't have to actually go into the office to have your pacemaker information recorded and given to your clinician. You can actually connect your pacemaker or your defibrillator via Wi-Fi, or even via Wi-Fi to a device, which can then read all that information, upload it into the cloud, send it to your provider, your clinician, and then your clinician can review it and identify things that may be off or wrong that need to be followed up, or give you a call and say, hey, everything's looking good, connect again in 3 months and I'll receive that information back at that time and then do another review. So, we also have home-based electrocardiograms or telemetry that we can use to monitor patients who have abnormal heart rhythms. We have a set of interventions that we deploy for patients who are. We actually have a partner organization named DUXLink, which we recently brought in to the CVA USA network of practices, and that DUXLink organization is solely dedicated to managing patients in their homes largely through virtual or remote monitoring technologies and telehealth-based interactions. They can send people into the home too, and for some higher risk patients, they do that. But they have the ability to gather a ton of information about how a patient is doing through a variety of monitoring techniques, including blood pressures, weights, the electrocardiogram that I mentioned, oxygen saturation monitoring. They use Alexa to interact with patients and gather information from patients about how they're doing, and then use all that information to help manage a patient very closely in their home and help them to remain in their home unless they're really, 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 really sick. And they've demonstrated the ability to reduce hospitalizations, reduce costs of care for patients with multiple chronic conditions, cardiovascular conditions, including heart failure, atrial fibrillation, coronary artery disease, and multiple conditions within that group. So we have a heart failure program as well, which is largely virtual, which delivers evidence-based counseling and education to patients in the comfort of their home via a remotely located clinician and a health coach, and uses remote patient monitoring, the blood pressures and weights and oxygen saturations that I mentioned, to help manage and monitor those patients' vitals and their weights look for early signs of decompensation in between those visits and between those visits with their clinicians. So just two examples of services and, care model innovations that we're deploying at scale across parts of our network to help better manage patients.
One of the things I'm curious about, because with the right patient adherence, I would imagine it makes your job a little bit easier. So people are hooking up to their EKG and it's connected to the internet. They don't have to haul it into your office or to the practice to get the data off of it. Once again, and not meaning to be tongue in cheek, but an issue with your heart or your lungs or these mission critical systems for your body. Do you find that patients are pretty adherent? I mean, I think about, God forbid, if I end up in that 40% with an issue that we're expecting to see, I'm going to be on top of it because I don't want to die because I didn't do something that was as simple as hooking up to a monitor. What's patient adherence like?
For these interventions, you mean, or more generally, just with medications?
I think more generally, if you have a thought, medication adherence is one thing. But even the remote patient monitoring aspect of this.
Yeah, I think so. What I think what we've started to learn is that there are certain barriers to adherence that exist across our healthcare system. Right, those are a lack of understanding of the intervention, or what a patient lacks understanding of what it is that they should be doing. Often when people are not taking their medicines, it's because they don't really understand, A, that they were supposed to take the medicine, B, when they were supposed to take it, or C, why they were supposed to take it. And so that's oftentimes a failure of our failure, right, in terms of our ability or how well we educated the patient about the medicine or addressed questions that they have about the intervention, the medicine. The others relate to cost. So we know that particularly for medicines which are, on patent, for example, and are more expensive, have higher copays or cost shares, those copays or cost shares really do impact the likelihood that a patient will take the medicine. And so asking them before you prescribe the medicine whether or not they have concerns about their ability to pay for it can help identify circumstances in which a patient is less likely to be able to adhere to the medicine. You have issues of access. So even if you address all of those questions, you address their concerns, you help them to understand why it is that they're supposed to be using a medication or adhering to an intervention. You've asked them about whether or not they have the ability to pay for it. They may not be able to access the intervention, meaning they may have mobility challenges which prevent them from going to the drugstore to pick up a medicine, or they may have difficulty standing up and walking to the door or walking to wherever they need to sit in order to connect to Wi-Fi and have the information from their mobile intervention downloaded via the internet to their provider to be used to help care for them. So there are a whole host of challenges and barriers to adherence that have been well documented through research and clinical experience over decades, but which in practice do impede the ability of patients to use the things that we know work. And it's our job as healthcare professionals, as clinicians and parts of the broader care team to help identify those barriers in the day-to-day work that we do caring for patients and do our best to address them. And that's hard work. It often is not reimbursed. And so, and I should say, Medicare has and other payers have started to put in place ways to actually get reimbursed for some of that care coordination, care management, education time. And that has, I think, helped to kind of unlock the ability to address some of those barriers in the course of delivering care. But those are fundamental issues that we have to address as a society. And I haven't even talked about kind of, I've skirted around social determinants, but a lot of what I've described relate to, relate to social determinants, right? Access, affordability, et cetera. You have language barriers. You have many other barriers to adherence, which I think really, really do impact our ability to implement interventions at scale and in practice.
Well, and that's the whole point of value-based care, what you're talking about too. I don't have to tell you, if you
No,
are
that's right.
if you're
That's
reimbursed
right.
and compensated for an over and above what is today an over and above intervention on behalf of a patient, you're hopefully keeping them out of the hospital as opposed to watching a tragedy in slow motion unfold. I can't get their data. I know they're not
That's
taking their medication, but at the end
And
of the
so,
day, I'm operating
yes,
a business and not a charity, which is a tough way to look at it,
yeah,
but it's the hard truth.
that's right. It is absolutely the hard truth, and part of the vision, and part of what I think is so exciting about value-based care is that when it works right, works correctly, it gives you the resources that you need as a clinician to address a lot of those barriers, right? You have the ability to hire the care manager. You have the ability to hire those other members of the care team, but beyond you as the physician, or you as the nurse practitioner, to help extend yourself, address those factors which are so critical to address to drive better outcomes. And the fee for service incentives that we have right now are not consistent with that vision for how care should be delivered. And so, what I spend a lot of my time doing is thinking through how we can design not just the care model, but also design the contracting approaches for cardiologists and for patients with heart and vascular disease to enable some of those resources to exist in and around the cardiovascular care specialist. Because the cardiovascular care specialist, for a subset of patients with heart and vascular disease, is a really critical member, is really at the center, I would say, of the care team for a subset of patients with heart and vascular disease, and plays a really integral role in the delivery of care for patients with heart and vascular disease more broadly, whether it's in the hospital or in concert with the primary care physician as a partner. And we do view PCPs as very important, critical partners who we work very closely with and who we coordinate with. So I think there's a real, we view a value-based care, risk-based contracting payment structure as actually being very much in line with how we think cardiovascular care should be delivered and paid for in the future, and that it will incent the delivery of better care at lower cost.
Hard to argue with you, Dr. Blumenthal. I mean, that, in my opinion, my non-expert opinion here, the first step to fixing healthcare, right? Everybody can see the big numbers that we spend on it. You talked about percent of GDP for cardiovascular care. It's even worse when you look at healthcare as a whole. And when you look at the 25% of the healthcare spend that's wasted is on administrivia, like administrative tasks and burden, that just makes me sick to my stomach. So that value-based care helps to get that value chain back in alignment. The delivery of care, fee-for-service value chain, not necessarily aligned between the three main parties, the provider, the patient, and the payer, obviously. And I'm hoping I can put you on your soapbox just a little bit, that if we do get that value chain in alignment with value-based care, we want people to remain healthy. What do you see as most critical to avoiding those unforced errors as a patient? And this is a silly example, but maybe not eating McDonald's 3 times a day, driving your blood pressure through the roof, and giving yourself hypertension. I mean, that's silly, but something has to give, because there are a lot of self-inflicted errors when people are talking about people's health.
There are a lot of self-inflicted errors. I think, man, I think that it's hard. it's hard to argue with the McDonald's example. You shouldn't be eating McDonald's 3 times a day.
It's good. It's not that good.
Yeah, I think there was a movie, right? There was the documentary showed that, I'm blanking on the name of the documentary, but the fast Super Size Me. Thank you. I'm thinking of the book Fast Food Nation, but yes, there was I think we know that that's not good for you. There are a few other things. So I mentioned diabetes earlier in this show, and we also have the diabetes epidemic that we face is related to the obesity epidemic that we face, and I think a lot of that, there's several reasons why we are as a nation getting bigger. From an eating standpoint, I think we drink a ton of sugared soda in this country, and that to me is just a waste, right? So this is one very small example, but it's a bit of a pet peeve of mine, and so I thought I would highlight it. The second, kind of zooming back out, is I think that patients need to, in many cases, in a system which I wish would always look out for people, but which doesn't always look out for people. Patients, I think, need to really focus on being their own advocates. And if they can be their own advocates and push for what they think they need, what evaluation they think they need, push to be educated about what's wrong with them, what their clinician is thinking, I think that can do a lot of good. I have seen circumstances as a clinician where patients have advocated for themselves and gotten treatment that has been critically important for them. I have friends, physicians, who have had to advocate for themselves to get needed care, and have, as a consequence, had really important diagnoses identified that wouldn't have otherwise been identified. So it happens to everyone across this country. And I think the more that individuals can advocate for themselves, the more likely it is that we will make sure that we hold the healthcare system accountable for doing the right things. So just one other example that popped into my head that I thought I would highlight.
What does that look like? You go into an office, something's not right. And physicians
I think
test, but something's not right, and I need to know exactly what it is.
Yeah, I think you have to say, listen, like, I'm not, I don't mean to say by any stretch that we as clinicians are not trying our absolute best to figure out what's going on, right? But they're, and to do right by patients. I fundamentally believe that doctors are doing as well as they are in general, trying every day to do their, and nurse practitioners and physician's assistants are trying to do their best in a system which is really broken and doesn't support them in the ways that we should be supported. But I think that looks like asking questions about what's going on, asking questions about why certain treatments are necessary or why they aren't necessary, asking whether there are alternatives, asking whether what they're feeling could be related to X or Y, instead of just asking, kind of asking the physician what they think is going on. If you have thoughts or you have questions, you should ask them or make them known.
It's as easy as that. Voice your opinion. Voice your concern.
Voice your opinion, right? Yeah.
Well, those are wise words. Let's pivot a little bit to one of the hotter topics you read about closing out 2023. It's died off a little bit in 2024. I think everybody's really excited about AI in medicine, but going into 24, there was a lot of buzz around certain cardio procedures coming off that inpatient only list and being reimbursable in the surgery center. We talked about the value chain. It's really tough to beat the surgery center for great outcomes, affordable for the patients, a place physicians want to do procedures, and we'll even give a nod to our friends at the payers that they get to pay less, so that makes them happy as well. What are your thoughts on that?
Yeah, I am a so you're exactly right. There are a number of procedures. Well, so first of all, in cardiology, we've been able to do procedures in ASCs for almost more than a decade. We've been able to implant pacemakers and defibrillators, to do diagnostic procedures, heart caths, to do necessary interventions in the leg arteries, the arm arteries, and more recently, Medicare has approved and doing stents for stable, severe blockages in the heart in ASCs. And I think we're going to see over time, and we saw this in the pandemic, right? By necessity, because there were certain procedures that were done in ASCs that hadn't typically or previously been done before, and payers relaxed some of their location-based requirements to allow certain procedures to be done in ASCs. And as a consequence, we were able to gather some information about those procedures, in particular right-sided ablations of arrhythmias, supraventricular arrhythmias, which have been shown to be performed at a high level of safety and efficacy in ambulatory surgery centers, based on several published case studies and case series, a lot of which came from the pandemic. So I think we're going to see a lot of additional procedural care continue to move into ASCs over the next 5 to 10 years from cardiology. And we need to continue to gather data on efficacy and safety, but almost everything that we've seen to date suggests that rates of efficacy remains equivalent to when procedures are done in hospital settings, and those procedures can be done safely, and patients are really satisfied and have a great experience. So it's a really, and I should also mention, costs are anywhere from 30 to 50% lower when you have the same procedure done in an ASC as when you have it done in a hospital or an HOPD setting, whether inpatient or HOPD rather. So we have really a win-win-win situation here for patients, most importantly, for providers, and for payers, and both public and private. And I think for that reason, we're going to see continued movement of procedural care, cardiovascular procedural care, into ASCs.
That cost savings, or the lesser cost that the ASC is opposed to the hospital, that should be staggering to people. And if you're not plugged in, it ends up being staggering. So this is a little bit of a long walk for a short drink of water here. We had Bill Prentice, who's the CEO and president of ASCA, the Ambulatory Surgery Center Association, on the show last year. And one of the things that he shared was one of the largest hurdles that ASCA, as the advocacy group for ASCs, is hoping to overcome is simply awareness. So if you're a patient and you hear 50% of the cost, or as much as 50% less expensive than going to the hospital, I have to do it there. There's no choice. I'm going to the hospital because that's a mortgage payment, that's a car payment, whatever the case is. So the question to you, doctor, is what would be your words to the wise for your fellow cardiologists to help spread the good word and to help ensure that if you can do a procedure at the ASC, that you can, if you feel that's the right thing in your clinical decision making, obviously.
Yeah. Well, there was one other thing. I think there was one point that I wanted to make about the payment, right? The payment differential is that those savings do get passed on, as you noted, to patients, because patients typically bear a percentage of the cost of the procedure in the form of a cost share. And so if you have a 20% cost share for a procedure which costs thousands of dollars, you have to pay 20%, whether it's in the HOPD, often depending upon your insurance arrangement, but in many cases, the cost share doesn't change depending upon the location. So you have to pay 20% of that procedure's cost, whether it's in the HOPD setting or the ASC setting. And so if you can reduce the total cost of the procedure, you reduce your total cost share. by a proportional amount. So that's a big deal, as you noted. I think that the message that I would deliver to cardiologists, my colleagues, is that I think, we are in many ways, I think, probably where orthopedics was 8 to 10 years ago in terms of the use of ASCs, the growth of ASCs, and that we should be thinking about how we can deliver the best quality care at the lowest possible cost and find a way to ensure that we are doing so in a safe, effective way and not shy away from using ASCs. In fact, embrace them. If we think that ASCs are, as the data suggests they are, the right place to do many of our procedures, particularly those which are, not in super high risk patients, are relatively routine, right? That part of the way that we improve the efficiency and the value of care that we're delivering in this country is by making important decisions about how to find a way to deliver care in the lowest cost setting. And ASCs are a great opportunity to do that.
Yeah, really.
That was a little, yeah, go ahead.
I was going to say, really, the only opportunity to lower cost and deliver the same standard of care as things sit today is at the ASC. And I don't mean to sound like too much of an advocate. I'm not on a pack for the ASCs in any way, shape, or form, but a big fan of the venue, and it's important for patients to have that option.
Yeah, yeah, and I agree, and I think I think we'll, we're going to continue to see them be more broadly used, and we do need to gather data on outcomes and track quality and safety outcomes. And there's several efforts afoot to do that. That's just part of ensuring that what we're doing is right, that we're continuing to improve. So I do think that's very important. And I wanted to mention that.
And you can see, if I can, you can see that data collection effort start to really begin in earnest. I mean, those of our listeners who are really policy wonks will know the ASC as a setting wasn't subject to the same meaningful use requirements as hospitals and practices were.
That's right.
So hard to really blame them after some of the early days of meaningful use, but for the most part, ASCs are not really all that digital. There's a big technology adoption lag across all of healthcare, and ASCs are even 10 years behind that. But we're seeing that change, and leaders in the space have acknowledged that, saying, hey, it's in our best interest to capture this data. We need to be looking at outcomes. We need to be looking at hospital admissions after a procedure is done here. How do we do it if we're not electronic? Because your
rates of complications, rates of complications. Yep. Rates of, as you mentioned, rates of post-procedural ER visits and hospitalizations. Those are in my mind, and there are registries which are being set up to do this, which I think will help us ensure that that the policy community and that outcomes researchers have access to the right information to do that work.
That's a place where that's a common theme for me today. That value chain is in alignment, and the particular ASC data value chain gets to learn from the lessons of the last 15 years and hopefully not make any of the mistakes that we've already seen happen.
Yeah.
Well, Dr. Blumenthal, as we kind of wrap up our chat here, is there anything else that we need to share with the audience? I think we've given technology at the point of care and talking through some of the grander population health issues. I think we've given them a fair shake, but what else do you want to add, if anything?
I actually don't have, I think we've covered a tremendous amount of ground in the last 45 minutes. I mean, I just wanted to thank you for your time and for having me on.
It really was my pleasure. I love getting to have this type of a conversation with experts in their field, and I know our listeners will want to be able to find you online if you're up for it. Are you big on any of the social medias? Where would you point people?
They can find me via LinkedIn. On X, my handle is @BlumenthalDM1, and then if via the CVA USA and Novocardia website. So it's www.cvausa.com, www.novocardiahealth.com.
We'll be sure.
Any of those.
get those links into the show notes so they're easily accessible for you. On behalf of the entire Doc Buddy team, Dr. Blumenthal, thanks again for joining us. To our audience, thanks for listening. Be sure you're subscribed on Apple Podcasts, Spotify, and YouTube so that you always get the newest episodes of the Doc Buddy Journal. And until next time, I'm your host, Eric. Talk soon.